Few housekeeping items. All attendees are muted and encouraged to use the Q&A box to ask the questions. Raise your hands or use chat for technical assistance. We offer dental, medical, nursing, public health, and chest and MCHEST continuing education credits. To receive credit, you must complete a survey. The survey link will be posted in the chat at the end of the session. Dental, medical, and nursing credits are offered at the session level and require a survey submission for each session. Public health and CHEST and MCHEST credits are offered only for the full day symposium and require one survey submission. Our speaker today is our very own Dr. Beth Giacona. Dr. Giacona is a board-certified pediatric dentist working in private practice in public health settings, including Zufall Health, where she supervises pediatric dental residents and provides care for underserved populations in New Jersey. Dr. Giacona is also an assistant clinical professor at Rutgers School of Dental Medicine, where her focus is on designing and implementing programs that increase access to care and promote oral health equity. She obtained her Doctor of Dental Surgery degree from Columbia University's College of Dental Medicine and has a Master's of Public Health degree from Yale School of Public Health. At the conclusion of this program, participants will be able to gain a deeper understanding of how health disparities affecting pediatric populations in the United States can have a lifelong negative impact in oral health, identify alternative methods of care delivery that help overcome barriers to accessing care in underserved populations, understand how alternative methods of care delivery benefit patients, their families, healthcare providers, and the environment. Now I would like to give the floor to Dr. Giacona.
Thank you, Daniel. Okay, so thank you for that kind introduction, and I am going to be speaking about alternative methods for delivering dental care to pediatric populations with a focus on preventive care. Next slide, please. So this is not news to anybody, but dental caries is the most common chronic disease of childhood. It is, in fact, highly preventable, and at the same time, both difficult and costly to treat. Next slide, please. Preventing caries is truly everybody wins situation. So the patients, prevention in childhood basically can have a lifelong impact for these kids. For dental providers, you can ask any practicing dentist, especially a pediatric dentist. We would all much rather do simple preventive procedures and get reimbursed from the insurance companies for it rather than wrestling with the child to get a filling done. When it comes to the payers or the insurance companies, whether those be public or private, restorations are more expensive. So they are very motivated to cover and encourage the use of preventive services. And for society at large, it's a quality of life issue. And children who grow into adults with dental problems can end up missing school in childhood, work in adulthood. Parents have to miss work in order to take their kids to the dentist, and basically paying for all these restorations is costing our health systems a lot of money. Next slide, please. So the ultimate goal of prevention is to do the greatest good in the most cost-effective manner possible. And that means that prevention has to happen early. Caries is a progressive disease process. Once the disease process starts, these cavities grow and grow and grow. And once a tooth is prepped for a restoration, it's important to remember that that tooth is, and I put quotation marks here because it's kind of a dramatic way to put it, but doomed, because restorations don't last forever. So eventually a restoration will fail. They have a life expectancy of between 5 and 15 years. That restoration needs to be replaced. When it's replaced, it's a bigger restoration. And then when it's replaced again, it's an even bigger restoration. And eventually we end up talking about root canals, crowns, extractions, and restorative or prosthodontic replacement. So I just want to highlight two terms that we use in public health. One is primary prevention. That's basically stopping the disease from ever starting. And the other is secondary prevention. So that's using screening and early treatment to result in better health outcomes in the long term. Next slide, please. And here I'm just highlighting a difference. This is kind of like an important theme in public health, the difference between equality and equity. So equality means everybody gets the same. It's a one size fits all approach. And this is not really optimal when we're talking about public health programs and designing programs. Next slide. What we want to focus on is equity, where the program is designed to meet the individual population's needs. Next slide. So I'm going to put this saying up here. It's kind of a little nugget to keep in mind, that the best dentists in the world are the ones working the hardest to put themselves out of business. So that's a little tongue-in-cheek, obviously. But the rest of this presentation is going to focus on the who, why, what, when, and how of delivering preventive care outside of our traditional clinic or office settings. Next slide. So the first is who. Who are we targeting with these preventive measures? Next slide. So some good news. Overall, based on data from NHANES surveys, cavities are on the decline in the United States. You can see that in this bar graph here. So going down at the last NHANES surveys for which we have published data from 2015 to 2016, they are on the decline. Next slide. But the not so good news. We in dentistry have a saying, especially in pediatric dentistry, that 80% of decay occurs in 20% of children. Who are these unfortunate children? They are children living in low-income households. Children in low-income households are almost twice at risk of having decay in their permanent teeth compared to those in higher income households. Racial ethnic minority children also are at higher risk, with non-Hispanic, Black, and Latino children having higher prevalence of decay than non-Hispanic white children. And this is data from the CDC. Next slide, please. So why? Why do these children have higher rates of dental caries? Next slide. It comes back to those social determinants of health, a recurring theme throughout today's symposium. So caries is a multifactorial disease. There are components of diet. In low-income neighborhoods and disadvantaged populations, they often live in food deserts. They have issues obtaining high quality and affordable foods. They tend to eat more cheap and convenient food items that are lower in nutritional value and higher in carbs and other unhealthy ingredients. There's the bacterial component of dental caries, where vertical and horizontal transmission plays a role, the so-called genetics of tooth decay. Then there's oral hygiene. So oral hygiene practices rely on a health belief system and health behavior change, which is hard, and we'll get to in another slide shortly. And then, of course, where we're really focusing on today, where we can really make a big impact, access to care. So we have the fear of what out-of-pocket costs might be when trying to access dental care, difficulty finding providers who accept public insurance plans. There's issues with transportation, and there's issues with caregivers not being able to take their kids to dental facilities during the hours that dental facilities are open. Next slide. So what can we offer for preventive care? Next slide. Well, oral health education. So everybody knows, I mean, it doesn't, you can ask anybody, they know, eat less candy, eat less carbs, brush your teeth. So you're not really telling people, newsworthy items, but getting them to change their health behavior is very, very difficult. Repeated messaging certainly helps. And it is important to note that children are more likely to adopt habits far more easily when they're young and then carry those healthier habits into adulthood. So again, that timing component is coming into play. Next slide. So if you look at evidence-based dentistry, oral hygiene and diet, we don't actually have a body of scientific evidence to support their impact on dental caries. We do have a large volume of evidence to support the effectiveness of community water fluoridation, to support the effectiveness of topical fluoride. And that means topical fluoride in the daily use of fluoridated toothpaste. So that goes kind of, intertwined obviously with oral hygiene practices, but also in a professionally applied fluoride varnishes. And then dental sealants. Next slide. So topical fluoride. We all know as dentists that fluoride incorporates into enamel. It makes it harder and more resistant to cavities. And that clinical trials, and I'm mentioning the numbers that were obtained from a systematic review that looked at a large volume of data, show a 37% reduction in cavities for primary teeth and a 43% reduction in cavities for permanent teeth. What is a fluoride varnish application? So simple, right? It's just opening this packet and brushing on this kind of jelly all over the teeth. It's quick and easy to apply. It's also, I guess we're advancing a little fast now. It's also easy. There are, I think, Miriam, we're going a little crazy with the advancing.
I'm sorry, where are we? Should I be going back?
Yeah, back a few to the fluoride varnish.
Am I moving back or am I moving
Nope,
forward?
you're moving forward.
Oh, goodness. I'm sorry.
No worries. Back a little, one
My
more.
apologies,
Oh,
everybody.
no worries. Oh, then we could go forward one. Perfect. So fluoride varnish is actually approved for reimbursement by non-dental providers. So that means that pediatricians, school nurses, other adjunct healthcare professionals can actually get reimbursed from state insurance companies for fluoride. Oh, it's advancing again. Okay, it's got a mind of its own, I guess.
I think you may have turned on auto advancing. So I'll just keep hitting it back.
It's going to be a battle. And then here in New Jersey, as just an example, we actually had some advocates that approached the state, New Jersey state, and they got legislation to be approved that fluoride varnish would be covered no matter the frequency or the location of where it was applied. So this way we didn't run into the issue of if we go into a school or a community center and we apply fluoride and the kid just went to the dentist 2 weeks ago and had fluoride, that fluoride wouldn't be reimbursed. So just something to keep in mind, especially for those of you who are attending who might not be in the state of New Jersey. Next slide, please. So dental sealants. I don't think anybody in this webinar anything new, but they're basically resin-based coatings that go over the deep grooves and fissures of permanent molars, especially those first permanent molars that erupt around age 6. These first permanent molars are actually the sites where 90% of tooth decay develops in the permanent dentition. Sealants are also easy and quick to apply, not as easy and quick as fluoride varnish, but nonetheless about less than 1 minute per tooth, absolutely painless. And they can be applied in a wide variety of settings using portable equipment. We have resin-based sealants, glass ionomer-based sealants. If we can go back, Miriam. Thank you. Perfect. And then some people are actually starting to use sodium diamide fluoride as a sealant. The benefits last for years, and a big systematic review that was published showed that sealants can prevent 80% of cavities over 5 years or more. Okay, next slide. So what else can we do when we're delivering care in the communities? Well, we can write up a dental report card that goes home to the caregivers, explaining what procedures were completed that day, and then what our clinical findings were. Basically, usually a report card is pretty straightforward. We say no caries, yes caries, and then divide the caries into non-urgent or urgent/emergent needs. We always send out information with explicit contact information for the caregivers to bring the kids to brick and mortar dental homes and get comprehensive care. Some cases we might schedule for a return visit. In other words, go back out into the community with our equipment to do operative dentistry. And then sodium diamide fluoride is another thing we're going to talk about in the next slide. So sodium diamide fluoride, what is it? Well, it's really just a liquid applied to what would ideally be a dry tooth surface, and it arrests carious lesions. I tell my parents in practice that it doesn't fix the cavity, but it stops it from growing any bigger when in the best case scenario. So it's made of silver, fluoride, and ammonia. The FDA has approved it for treating sensitivity, but we have been using it for quite a number of years now off-label to arrest clinical caries lesions. It is covered by Medicaid in some states as this D1354 code. There is not yet an established strict protocol on how to use. So in other words, how many applications do you put it on, fluoride varnish afterwards, and can you put a smart restoration with glass ionomer over it once you have the caries arrested? Next slide, please. So in clinical practice, like I said, I tell my parents it does not fix the cavities, but it stops them from growing larger. You do not need any special equipment whatsoever. You can just do it in a regular old, whatever chair on the floor, it doesn't matter. It's quick and easy and rapid to apply. It basically can buy you time while you're waiting to schedule the operative dentistry. So whether you're waiting for an office setting to be available, a hospital appointment to be available, or for the child to just mature so that you can just do regular dentistry in the chair. It can be very, very effective when used with the glass ionomer restorations on top of it, called the SMART technique. The biggest downside is that it does stain the cavity very, very dark black. And it's a permanent stain. So there's questionable use on whether you would want to put it on anterior teeth. In other words, does the dark staining that results actually make the situation worse? Next slide. Okay, I don't know what that thing, but I think that's going to be, oh, when, there you go. It took its time. Next slide. So when should we be doing these, right? Remember we said earlier, the better. So fluoride is definitely most effective on newly erupted teeth. It's just that the enamel is kind of more porous, if you think of it that way. But fluoride and sodium diamide fluoride can be effective really at any time and any age. Sealants, we want to get them on those first molars as soon as we can. And those are called the 6-year molars, meaning that the typical average age where they erupt into the mouth is 6 years of age. These are usually kids in kindergarten through about 3rd grade. Oral hygiene habits and dietary counseling. As I mentioned earlier, it's much easier to establish healthy habits and to keep those healthy habits going if you get the children on board when they're very, very young. You can't teach an old dog new tricks, right? You've heard that saying. So the earlier, the better. But again, it's never too late. Next slide. So we have to keep in mind that we really need to tailor whatever program we're going to try to implement to fit the community's needs. So there has to be some amount of flexibility on the behalf of the providers. We need to think about doing these interventions, offering these interventions before school, maybe after school, maybe on the weekends. If we do it during school, maybe there's a health period that we could kind of piggyback to, or a study hall, or in the younger kids, during their circle time. A lot of schools, Title I schools especially, offer summer programs. They go year round. And in the summertime, the schools tend to have a little bit more flexibility with their schedules. So sometimes it's a lot easier to schedule these interventions in a school during their summer months when they're open. Again, you could do it during extracurricular or sporting events, looking at boys and girls clubs, looking at after-school basketball or soccer or baseball programs. You can always try to work it in conjunction with local health fairs. Give Kids a Smile Day is a great opportunity to provide these services and other community events. And then it's also nice to couple these dental interventions with other medical or social interventions. Next slide. So how do we do this? Next slide. Well, first and foremost, we need to engage the community. We need to get buy-in. So you have to go out, hit the road, and establish relationships. Contacting school nurses, teachers, school administrators, the principals. You need to basically identify and engage with an oral health champion. So how do you do that? Well, countless hours of giving presentations to school officials, to families, to the students. You have to get buy-in in order to succeed. And then it's important to collect feedback. What do your targeted end users really want or need? And how can you align your goals to meet those needs and desires of your targeted population? So you design your intervention, but you have to be ready and willing to redesign and adjust as needed. Next slide. So how do we hit the road? Well, two kind of main classes here. We can do it with portable equipment or vans/mobile units. Next slide. So portable equipment. First of all, we don't even need portable equipment for SDF or for just doing screenings or applying fluoride varnish. It's not too costly to invest in a portable equipment setup for doing school-based sealants. So if you're talking about getting a patient chair that reclines so that the patient can lie kind of horizontally, a high-speed suction unit, especially if you're using resin-based sealants, you kind of want that, and then a curing light, it all amounts to less than $10,000. It does get more expensive if you're going to purchase portable equipment to actually do restorative work or to take x-rays, because the handpiece and delivery units are a little bit pricey, as is a Nomad or a portable x-ray unit. But the portable equipment can be set up really almost anywhere. So in a school, you can find a multi-purpose room, a cafeteria, the nurse's office. You can set it up in a library, in a community center, in a gym. The staffing needs, so how many other people you would need to bring besides your provider, really correlate to what services you're going to be offering. Next slide, please. Dental vans. Dental vans, now we're talking big money, right? Especially for the initial purchase. There are high maintenance costs, there are operating costs. If, depending on the size of your van, it may require a licensed operator with a special, commercial vehicle license. It requires a parking spot. Parking these mammoth, Winnebagos is no joke, especially if you think about going to an urban center. But the dental vans are so lovely because they can provide a full range of dental services. Next slide. So right now, Zufall has this wonderful dental van, our Delta Dental, primarily sponsored dental van, and it has been parking in the Franklin Township Middle School parking lot 2 days per month. When we first started going down there, it was the goal was to go down, screen the kids that had needs. The van would come back and do those restorative needs. But again, in that iterative process of engaging with the community, things kind of shifted because the community told us that they would rather us focus on screening as many kids as possible and then referring those kids to brick and mortar dental places for treatment. I'd like to, at this point, give a very special shout out to Dr. Maeda, who works here at Zufall, who is like the tireless warrior basically on that van. She's an amazing person, so generous with her time, and really is one of the most caring public health dentists I've ever met. And then I'll put a little side note here as far as community support. People just love seeing that van pull up. People love mobile health units. So it's kind of a good PR thing to have. Next slide, please. So basing programs in school, I took this photo actually in Panama, in a little town in Panama, a rural town called Bermejo. And I think the reason I put it in here is because the school, whether it's in this tiny little hamlet of Bermejo, Panama, or if it's in Newark, New Jersey, a school really can serve as the center of the community. It's a way to really engage with the families. This is a place where the most important thing in the family, right, the thing that they love and treasure the most, their own children, spend the bulk of their days every day. So when you're in that school, you're really working to make sure that your relationship is leveraging trust and respect for the school, and that school is helping you to gain the buy-in from the families that you're trying to serve. And remember that health behavior change, that repeated messaging, that focusing on the importance of oral health, it takes a village. So if you've got the school on board and the school is also backing you with this, your chances of success are much higher. And the school will benefit too. Next slide. So school also has is impacted by oral health, because school readiness physical health is really a key component of school readiness, and oral health is part of physical health. And studies have shown that children with poor dental health are nearly 3 times more likely to miss school, and children with dental pain are 4 times more likely to have low grade point averages. So there is an impact on the school as well. And therefore, they have motivation to improve the oral health of their students. Next slide. So what about putting a clinic in a school building? Well, what a wonderful idea, right? That really eliminates a lot of barriers. We're taking transportation completely off the table now. Parents don't have to be there. They don't have to take off from work. They can pre-sign the consents. They don't have to worry about getting childcare, for younger siblings that might not be in school yet either. It improves health outcomes for sure. Basically, now you have a captive audience. If the student is already in the building, unless they've been out sick that day, you're virtually eliminating any chance of a broken appointment or a missed appointment. You can time the interventions. You have the kids in the school, so you can get those sealants on pretty much as soon as those permanent molars erupt. And then I'm going to mention this a little bit later in another slide too, a couple slides in the future. But as utilization for all services go up, emergency department usage goes down. So we see less dental emergencies, less even medical emergencies if you provide medical services too. Next slide. So Zufall right now is working with the Franklin Township School, the place where I said that the van is now going twice a month. And we are trying to actually construct a clinical facility. It's under construction, I should say. So we have started construction on the school's property. This facility will provide medical and dental services, so comprehensive health care. And these services will be provided for the children of Franklin Township, but also for the entire community. And where those services are going to be convenient, they're right there in the school property, accessible and affordable. Next slide. So what are some side effects of school-based dental programs? Next slide. So mostly the side effects are all good, right? We're eliminating barriers like transportation, parents needing to take off from work. We're reducing time missed from school because we're scheduling these appointments during extracurricular classes. There's no commuting time. The kid doesn't have to be picked up at 9 a.m., go to the 10 a.m. dentist appointment and then return to school, at noon and miss half a day. They walk down a hallway and it's a matter of minutes before they're at their dental appointment. We're increasing access to care. Obviously, we're bringing the healthcare right to this place where the child spends most of his or her day. And like I said, there's actually been a study where it showed when they had a clinic in a school that provided medical and dental services, they saw a reduction in the population of students that was enrolled to receive primary care services in that facility, in that school-based clinic. They were less likely to end up in the emergency department than students in the same school who had not enrolled for services in that school-based clinic. And as we know, primary and secondary prevention works because most emergency room department visits were really non-urgent issues that if these kids had a primary care provider, that would be where they would go with these problems, not having to go to the emergency room. Next slide, please. So all stakeholders benefit when we're talking about school-based preventive programs. The kids, we increase their access to care. We're decreasing their risk for cavities using evidence-based interventions. We're reinforcing healthy behaviors. We're doing repeated messaging and stressing the importance of oral health and that now is the time to start taking care of your teeth. You'll have a lifetime of benefit if you do that now. And then as a little, interesting side effect, but they get to see the dental providers that come in to treat them. And maybe they'll see somebody that looks like them and think, my goodness, I never thought about dentistry, but look, Dr. Jones was so lovely. Dr. Maeda was just so wonderful. I think when I grow up, I want to be a dentist or I want to be a physician as well. The school itself benefits, right? They have the improved oral health of the student population, so less school days missed because of dental caries. It really helps to strengthen ties between the providers and the community. And it sends a message from the school to the families that we all care about your students' health. For dental providers, it's a way to generate some significant revenues by charging the insurance, for billing insurance. And these can help sustain and expand programs. And again, it just strengthens ties between the providers and the community. Next slide, please. So how do we do, once we have missed the boat on prevention, how can we meet restorative needs? Next slide. So when it's too late, right? Now we have dental caries. So again, we can talk about mobile dentistry using either a van or some kind of mobile dental unit, or that portable equipment. Again, the portable equipment you need for doing restorations is more costly than what you would need for doing preventive interventions. We can use those clinics if we're lucky enough to have one in school buildings, but we do need to keep in mind that children in lower socioeconomic status tend to have higher treatment needs. And if they're very young children, this means that there's going to be a higher need for dental rehabilitation under general anesthesia. Next slide. So what are we talking about with dental rehabilitation under general anesthesia? Well, it means that everything gets done at once, but the child is completely asleep. And it can be very difficult for these families that need this service to find providers that have hospital privileges that will take their insurance. Also, there can be incredibly long wait lists for operating room appointments. Most facilities, most clinics or dental schools or community health centers that do have the ability to take children to the hospital to get their dental work done in the operating room have 6 or more month-long waiting lists. In fact, I just went to a lecture and found out that University of Michigan Dental School, their wait list is almost 3 years long, which is just insane. The hospital itself can create barriers to care because the hospital might be, a real issue as far as accessing in regards to transportation, especially if you start talking about people who live in rural areas where the nearest hospital might be over 2 hours of drive away. There's insurance coverage, whether or not a patient's insurance will cover the hospital and anesthesia fees, which run upwards of like $20,000. And then there's all sorts of issues with case cancellations. There's kids get sick, then they need to be rescheduled, and then it's another few months that they're waiting for care. There's insurance authorization or pre-authorization issues. Parents who have trouble finding childcare because this now is not just even a 1 hour long dental appointment. This tends to be quite a few hours that you'll be spending at that hospital. Next slide, please. So here I'm giving out just kind of another shout out to a group of anesthesiologists. I don't know them personally. I know people who do know them, but this group of originally 3 anesthesiologists decided to get together and provide mobile anesthesia services, general anesthesia services. So mostly they're serving in rural areas in the middle of our country, Ohio, Kentucky, and Tennessee. What they do is they bring in doctors, nurses, support staff, and all the equipment needed to dental offices. So it reduces some of the barriers associated with the hospital setting. Most dentists are most comfortable doing dental work in their own offices, as opposed to how awkward it can kind of be to try to get dental work done in an operating room setting. The patient transportation barrier is eliminated if there was one, if the nearest hospital is 2 hours away, but that dental office is only 10 minutes, say. It reduces costs to the health system because, again, facilities and anesthesia fees at hospitals or surgery centers are very, very, very high. And it typically reduces the wait time for an appointment. As I said, most facilities or most clinics that offer hospital dentistry, those patients are waiting 6 to 18 months typically. So this really reduces that wait time to usually a matter of weeks. Next, please. So here I'm going to kind of pivot a little bit just to bring in something a little different, but and introduce another stakeholder as the planet Earth. So bringing dentistry to our patients directly actually helps mitigate climate change. Next slide, please. So climate change, we all know, or I hope we all know, that it is really a tremendous public health crisis right now. And here in New Jersey, we're all suffering through this incredible record-breaking drought related to climate change. What's causing climate change? Well, global warming, and that's from all the carbon emissions that we've been producing, causing all these extreme weather events and famine, and infectious disease has been on the rise. And really, climate change is caused by richest nations in the world. We produce the most carbon emissions, and unfortunately, the worst effects of climate change tend to be felt by the poorest people living on the planet who really don't produce much as far as carbon emissions. So it really is an unjust situation. Next slide, please. So how do we reduce carbon emissions by school-based or community-based dental prevention? Well, studies out of the UK have shown that 2/3 of carbon emissions from dental practice actually come from travel, about 1/3 coming from patient travel, and about 1/3 coming from provider or staff commuting to an office. So if you think about taking your show on the road and going to the patients, then you've already eliminated that 1/3 of those carbon emissions from patient travel. Next slide, please. The same group of researchers have also calculated out the carbon footprint for different procedures. So you can see how a fluoride varnish or a sealant, the carbon footprint is in the 5 or 8 kilograms per carbon equivalent as compared to restorations, whether it be composite or amalgam, and then especially restorations if you need nitrous oxide in a pediatric patient to put that restoration into place. So even without the nitrous oxide, if you look at what the reduction in carbon emissions from just doing 1,000 effective sealants could be as far as preventing the need for composite fillings on those 1,000 teeth, over 6,000 carbon equivalents. So pretty impressive. Next slide. So what are the ultimate goals of interventions? Well, we need to address these disparities. We need to help this 20% of the children that are getting 80% of the cavities. So we have to remove or reduce the barriers that are to accessing good quality preventive services. But we also have to design for sustainability. I mean, money rules the world, right? So programs must fund themselves in order to exist and to continue to operate. We really need to try to make it as our goal to create these win-win-win situations to ensure that all of our stakeholders benefit. Next slide. And we need to keep in mind this overriding goal, not do a one-size-fits-all, not focus on equality, but rather focus on equity. So again, it means engaging the target population and assessing the needs, designing your program to meet those needs in a sustainable and equitable way, and then monitoring and evaluation to confirm the program effectiveness. So you have to continuously monitor and evaluate to make sure that your program is still evolving to meet the community or the target population's needs. Next slide, please. And finally, I'm going to end, this is, I think, probably my last slide, I think, to talk about acting locally, but thinking globally. So really, I would encourage everyone here in this webinar to think about where your talents and strengths lie and how you can leverage those really from at the patient level to the population level. So maybe you are, you just love being in that dental chair, you're a wet-handed dentist, you just, that's your jam, that's what you like to do, and you have a private practice and you're doing really well and you enjoy it. That's fantastic. Maybe you might think about joining a community health center or opening up your office, say one day out of the whole year for a Give Kids a Smile event, where you would be supported too by the American Dental Association to provide free services that one day out of the year. And then it's a way to give back. It's a way to engage with your community, and again, really focusing on what you have to offer and where your passion lies, and leveraging that to do the greatest good, right, for our community. And then a couple of quotes from Paul Farmer, one of the most wonderful human beings, I think, ever to walk the planet. Paul Farmer was, for those of you who don't know, he was a physician, and he was really focused, he focused his career on trying to eliminate disparities in healthcare. And he was absolutely heartbroken and devastated after visiting Haiti as a young man, and seeing these people living on the island of Haiti in just absolute abject poverty. And he was just absolutely devastated at the thought that it seemed people really didn't care, that if these people were poor, they were somehow, they didn't deserve to have health care. They didn't deserve to have the good health that richer peers were entitled to. So this quote is from him: "The idea that some lives matter less is the root of all that is wrong with the world." And I would say that this is particularly wrenching when you think about children, and the fact that children, first of all, they didn't choose what family to be born in, or what circumstances to be born in, and they really have no way to change the circumstances that they live in. And that these children, when they're really, really young, if they are not getting access to these evidence-based interventions, can suffer for the rest of their lives the devastating consequences of a truly preventable disease like dental caries. And then finally, it's very expensive to give bad medical care to poor people in a rich country, that Paul Farmer also said. So in this quote, I would say that it's true for dental care as well. By not giving dental preventive care to these 20% of children that are experiencing 80% of decay, as a society, we are all going to pay more for the restorative care that they're going to need because we didn't give them the preventive care. And we're going to pay more through our insurance, through public insurance, paying more for those restorations. We're going to pay more as a society for lower quality of life for these people and for missed days in school and in the workforce. So it really makes a lot more sense to do the right thing and to really try our best to deliver evidence-based preventive services, dental services, to the kids that need it most. Next slide, please. And that's my final slide. So thank you very much. I'd like to thank, in particular, Zufall Health Center, and all the support that I've had over the years here. This is a wonderful place to work. And anyone on this call right now who is not a Zufall employee, I would encourage you to explore Zufall as maybe a partner in your career as a healthcare provider. And thank you all for attending and for your attention.
Thank you so much, Dr. Giacona. I think we want to thank you for just being here and sharing your expertise and your skills with all of the underserved populations that really need your help. So thank you. And what an interesting presentation. And I think we all agree that prevention is definitely the key. So thank you. We are going to now move to a couple of questions. We do have time, so just bear with me here. There's a few about fluoride. I'll try to just quickly condense here. But so who or what entity determines whether fluoride is allowed or removed or enter into the city water?
So that is that is at the policy level. That is legal and political. So each, here in New Jersey, most communities do not have fluoridated water. There are actually, I think, only 6 or 7 municipalities that have fluoride throughout the state. We are the second lowest as far as percent of the population that gets fluoridated water, second lowest out of the list of 50 states in the US. Hawaii is the lowest.
Right, great. This second one also ties into the fluoride question. With all the recent talks about removing fluoride from our drinking water, do you think this will impact programs using fluoride varnish to prevent cavities in children?
So I hope not is the answer. So as I mentioned in the slide there, early on in the presentation, really, when we talk about scientific evidence, there are only 3 interventions in dentistry that we have now, at least, that have been shown to be effective at preventing caries. 1, community water fluoridation, 2, topical fluoride, and 3, dental sealants. So topical fluoride, and this is what I tell in the years that I've been practicing, I did have many parents express concern over the topical fluoride, the fluoride varnish, basically. Oh, I read fluoride's really bad for you. I read that it's toxic, it causes this, it causes that. And I say, okay, well, that's, really all that information that's out there, and as it relates to water fluoridation, is related to systemic effects, to drinking, consuming fluoride, and having it go through your body. I said the topical is different, right? That's a topical effect, so it minimally enters your body. It really just focuses on the teeth themselves. But when it comes to the community water fluoridation issue, I think the claims that are really getting a lot of attention right now about the toxicity of fluoride, the scientific evidence behind those claims is, quite frankly, of a very poor quality. And a lot of those studies where toxic outcomes were seen from consuming too much fluoride, they were not done in the US, first of all, and they were done with very, very, very high levels of fluoride, so much higher than you would see in any water supply here in the US. That's pretty strictly regulated to make sure that it's only up to 0.7 parts per million, ideally optimally fluoridated water. What I will say is that, the claims that fluoride in the water causes cancer and causes autism, if you look at the state of New Jersey, which again, for the most part, has non-fluoridated water, the state of New Jersey has higher than the national average for prevalence of autism and for cancer. And you know what else it has higher than the national average for? Caries prevalence. The most recent oral health survey of 3rd graders in this state showed that we were above the national average for dental caries. So I really hope that in the end, science will win out, and we won't see a retraction of water fluoridation. I mean, water fluoridation is endorsed by the World Health Organization as one of the greatest public health interventions of the 20th century. And I think water fluoridation in particular, it's like a good example of social justice. It's very inexpensive. It costs less than $1 per person per year to fluoridate a community water supply. And it means that every child, no matter what their household income is, no matter what race or ethnicity they are, is getting an evidence-based intervention to help reduce cavities.
Amazing, amazing. That's, I think we all should also do more advocate work regarding these science-based benefits, so amazing information. I just have one more question. What do you think should be in place, or what other programs do you think would help to get some more providers to serve these underserved communities that are in so much need?
So that's a great question. It kind of comes down to what I spoke about in that very last slide about finding your strengths and finding your talents and finding your passion, what lights you up. And I think for a lot of people, they may not realize it until they're exposed to it. I think even for myself, in dental school, you're so kind of engrossed in this overwhelming information that you have to absorb, and trying your best to figure things out academically and technically, as a new member of the dental profession. But I think if you could, exposure means a lot. So if you can maybe seek out opportunities for volunteerism, or community events that you might attend, even if it's kind of as a background, or as just an attendee at first, and kind of check things out. I think also it is important to note that when we're talking about public health and providing services and designing and implementing interventions, that volunteers are wonderful, really wonderful, but volunteerism is not a strong foundation to build a sustainable program off of, because volunteerism is not it's not a workforce that you can depend upon as much as you can an employed workforce. And this comes down to that money rules the world, and designing for sustainability. I think that there are ways, and you have to really kind of take a deep dive into it and be very open-minded, but there are ways to make these programs, as I mentioned, into like win-win-win situations. So there are ways to not have to rely on volunteerism if you really, really do your research and you engage with the different stakeholders. And those stakeholders would be from Medicaid to third-party administrators in your state, to local organizations, to maybe even grants, foundation grants, or federal grants, federal and state grants, or the state health departments. So there's a place for everybody, and even if it's one day out of the whole year, to host a Give Kids a Smile event and this is what we used to do in one of the offices I worked in, that was a half a day a year, but the kids that came in that morning were so happy to be there, and we as providers, it was the greatest day of the year. It was really felt like you were contributing to society, and the smiles that you got to see made it worth it.
Awesome. Awesome. Thank you so much again, Dr. Giacona, and everyone who attended. Please remember to take the survey in order to receive CE credits. Very important. You will now be automatically routed back to the lobby to be able to join the next session. So thank you so much. Thank you all.
Thank you.